Well, no, thank you all and for coming out, and sorry for the delay. What I wanted to just spend the next few minutes talking about is the issue of behavior and Alzheimer's disease and why things happen. Now, we get very questions that seem to be very commonly asked, so I just wrote some of them down. One request we very frequently get is, please explain to him that he has Alzheimer's. He's in complete denial. So like we're supposed to explain to him that he has the disease. Another is, well, I tell him he should do something, but he just won't do it. Or his memory is not too bad. He can remember things from his childhood, but he can't remember anything recently. Another is, well, he just used to be able to fix anything. Now he can't even work the remote for the TV. Or, I can't take him to the buffet anymore. He acts so childish. He embarrasses you filled in out of me. Or he gets so angry over the slightest things. I put he, of course it could be she. Or I know he knows what he's trying to say, but he just can't express himself. So these are just common observations or questions that are brought to us. And the real question is, why do they occur? Because it's not just random that these are very common things in Alzheimer's disease. So just as background, and I know you all know this, but Alzheimer's disease is a neurodegenerative disease. It's not the same thing as dementia, which is actually more of a descriptive term, the term of severity. And we know it's characterized by this deposition or accumulation of abnormal proteins in the brain. So the amyloid, which causes plaques, and then this other protein called tau, and that's what you find in these tangles. So there's plaques and tangles. And it turns out the severity of the disease, and actually the symptoms of the disease, are more associated with the tangles than the plaques, even though the amyloid is deposited first in the brain. So this is just an example pictorially of what an Alzheimer's cell looks like. You can see kind of to the let's see. Well, it's actually both. That kind of brownish glump is the plaques, that's amyloid. And then that dark cell that seems shriveled up is full of tangles. So that's what you see pathologically in the disease. And many of you know this already, but really what's transformed our understanding of the disease is our understanding that the disease process starts many, many years before you even have any symptoms. So even though you may end up in your 80s with dementia, probably the disease may start when you're in your 60s. And that's when the amyloid gets deposited in the brain. And then it causes inflammation. That's the microglial activation. Then you get the tangles forming. The cells degenerate. And then you get chemical changes in the brain. So all these things just progressively get worse. And this can go over 20 years, even though the symptomatic part of it may be much less. Now, Alzheimer's is not simply brain aging. It turns out, of course, the older you get, the more likely you're going to develop a disease, whether it's Alzheimer's disease or small strokes or whatever. And in fact, if you make it into your 90s, it's more likely or not that you're going to have some memory problems for some reason, and Alzheimer's being the most common. Now, what I really want to get to the heart of today is that this isn't a disease that just affects the whole brain. And there are reasons why you see the behaviors you do. And I think understanding that helps you understand and be maybe more tolerant of if you're a caregiver. The other thing that's important is not everybody gets the same symptoms. So the disease, the timing of progression, the type of symptoms you see are not going to be the same from person to person. There's certain things that are common, and more often than not people get them, but everybody is in some sense a little unique as far as that goes. So what are the symptoms of Alzheimer's disease? So there are a lot. There's one group we call cognitive, or just kind of the mental symptoms, so memory loss, impairment of judgment or reasoning, difficulties with language function, comprehension, insight. Visual spatial skills are kind of knowing where you are directionally, knowing where you are in space, knowing what arm to put into what sleeve, and so on. But then there can be a lot of behavioral changes. And again, this varies a lot between people. Apathy, though, is a very common one. So people lose interest in activities. Certainly you can have depression. You can have disinhibition, where people become, they lose their ability to kind of control impulses. You can get agitation, anxiety, and sleep. So these are all very common symptoms as part of the disease. So why do they occur is really the question. Now, I'm going to remind you a little bit about the brain. And we artificially divide the brain up into different regions. I mean, there aren't actually, divisions in the brain. It's one thing. But we kind of divide it up because we know from a lot of study of the brain, even from understanding what happens with brain injury and strokes and electrical stimulation of the brain, that different areas, different regions have different functions. And so generally we divide the brain up into these 4 major lobes: the frontal lobe, temporal lobe, parietal lobe, and occipital lobe. The cerebellum is at the bottom. That's really not too much affected with behavior and cognition. It's more for balance and such. So those 4, frontal, parietal, temporal, and occipital lobe, are kind of the key areas of the brain that we assign different functions to. In Alzheimer's disease, as it progresses, actually spreads throughout all these areas of the brain. Now, the top set of figures is the deposition of amyloid. And the 3 different brains reflect 3 stages of the disease: mild, moderate, and severe. So you can see, even in mild Alzheimer's disease, if you look at the top, there's already a fair amount of amyloid that's kind of distributed through the brain. If you really look closely, though it's not everywhere, there's areas that don't have it. So it's not like it just covers the whole brain. But as the disease progresses, you just see this amyloid, the deposition kind of gets just more and more, and eventually almost the whole brain is covered. But on the bottom, which is the other protein, the tau, this actually spreads in a very typical pattern. So it starts out in the temporal lobe, we'll go through this, then spreads kind of up into the frontal area and a little in the back, and then it eventually spreads throughout the brain. So it kind of spreads from place to place. And that kind of explains why there's certain symptoms that happen. The areas that are generally not affected by Alzheimer's disease are noted here. They're kind of the orange areas. So one is the area of involved in sensation. So we think in Alzheimer's disease, people can, they have normal senses. The vision's not affected, the hearing's not affected, touch and sensation's not affected, taste isn't affected. Smell, though, is a little different. That's the only thing that's probably different. So sensation's not necessarily affected. Movement's not affected, so strength is not affected. And actually, as part of the senses, the vision area is not affected as well. So there's certain areas of the brain that just seem to be immune to the effects of these proteins that are being deposited. Now, the hooker here, though, is that even though you might see something, you also have to process that information. And in Alzheimer's disease, the processing can get affected. So you still can see, but it's just you can't make sense of what you see, and that can happen. Now, I want to go through the different areas of the brain and relate what they do to the behaviors you might see. So the temporal lobe, as we talked about when I showed you that map of how the disease spreads, is really hit hard early in the disease, particularly with the tangles. So what does the temporal lobe do? It has a couple structures in it. It has what's called the amygdala. So you can see that little area right at the front of what looks like a scorpion. Right next to it is the hippocampus. And then that whole structure just kind of flows through the whole area. So what does the temporal lobe do? Well, the hippocampus is the memory area of the brain. So if you injure or destroy the hippocampus, you will get difficulty with your ability to lay down new memories, to learn new information, to recall recent events. So basically, it's the short-term memory area of the brain. And that's affected early in the disease. And so not surprisingly, one of the earliest symptoms of Alzheimer's disease is loss of short-term memory, or impairment of short-term memory. Now, in front of that, we saw the amygdala. Well, that area, that's a very ancient area of the brain, and it's involved in emotion, emotional reaction, emotional control. So if you affect that, you can get dyscontrol. That is, you can have rage reactions. You can have increased emotionality, catastrophic responses. So little things then can kind of blow up. So it's kind of that area that when it's working, it helps maintain emotion and emotional response. But if it's not working, all bets are off. So you can have rage, you can have other things like that. The other part of the temporal lobe, at least on the left side of the brain, it is involved in language function, in word finding. So this is another reason why there's this kind of common phenomenon. Now, we all have it to some degree, which is, as you get older, you know what you want to say but can't find the word. Well, that becomes more accentuated in this disease, and if you happen to have more involvement of that left temporal lobe in certain areas, then that may be actually a very prominent feature early in the disease, because that's the area of the brain that's affected. Now, the other area that's affected relatively early, so as I say, if you remember, the tangles came out from the temporal lobe, they went into the frontal region. So what does the frontal lobe do? Well, it's actually a large area of the brain. Keep in mind that really it's the frontal lobe that differentiates humans from all other animals. So in other words, what really makes us humans is this development of the frontal lobe. So other animals have a very rudimentary frontal lobe, if any. And because of that, the frontal lobe is really what characterizes us as humans. So our ability to make judgments, to reason, to plan, to have initiative and motivation, to be socially appropriate with other people. These are all functions that seem to reside or be affected in the frontal lobe. Now, it turns out there is a little difference in kind of the left and the right side. The right side of the frontal lobe, if it's affected, sometimes will give you psychiatric type symptoms. So again, depression, delusions, things like that. So you get more involvement or more psychiatric symptoms if the right side is more affected. But you can see again, as in Alzheimer's disease, where you see loss of initiative or apathy from the frontal lobe involvement. Difficulty reasoning, where you have a situation where you're trying to rationalize with somebody and they just don't get it. Well, the reason they don't get it is because you get involvement in that frontal lobe. So you can talk all you want, but it's just not going to register. They're not going to be able to do it. Social appropriateness, where I think the common way we see that is in behaviors which are really disinhibited again. So where people are extremely friendly to other people, or that just don't seem to have the social boundaries that they previously had. And a reason for that is the involvement of the frontal lobe. So you can see temporal lobe starts, then spreads to the frontal lobe. And again, in Alzheimer's disease, not everybody has the same amount of damage to these different areas, and it's just where it is. It's like real estate, location, location, location. It's just where you find the damage occurring. Now, the parietal lobe sits farther back. That's in back of the frontal lobe. And you can see that actually is a pretty widespread area too. Now, the parietal lobe really does have distinct functions on the right and the left side of the brain. So on the left side, for most people, and I'll just, for full disclosure, if you're right-handed, then it's almost 100% that the language area of your brain is going to be on the left side. If you're left-handed, about 50% of people have the language area on the right side of the brain. So for most people, language area is on the left side, which is the area for comprehension. So to understand what's going on, understand what people. Now, if you're left-handed, that may or may not be true. But the left parietal lobe is usually involved in comprehension, understanding things, putting things together, being able to understand like what's your right side and what's your left side. I mean, just yourself. Being able to do calculations or more analytical tasks. So that's the left side of the brain. The right side is a little different. Right side is more for processing sensory information. So when you touch something, be able to identify what it is, even if you don't look at it. The visual spatial, which is, again, knowing how you are and how you're related to space. So that could be as simple as just not really getting directions and not being able to kind of know where you're going when you're driving or even in a house. You just can't get oriented to directions. Two, if it's more severe, things like not being able to know what arm goes into what sleeve and blah, blah, blah. The other thing that's really interesting about the right side, right parietal lobe, is this concept of insight into illness. Meaning that if that area is damaged or destroyed, people have what we call neglective illness. They don't think anything's wrong with it. It's really most dramatic, by the way, in strokes, where if you have a stroke in that area, which may paralyze your left side, so you get a stroke on the right side, so you may be paralyzed, but that person may think nothing's wrong with them. And that's the reason when people come in to ask us, well, just tell him he has Alzheimer's disease. He thinks nothing's wrong with him. You got to tell him. You could tell him till the cows come home. But they don't have the insight. And that's not going to get, you're just beating your head against a wall. But that's why it happens, because that area of the brain is probably affected. This is just an example of, as the disease progresses, how you see those changes manifest. So this is just a test of copying. You have to just draw a house. So you can see up the top part is what they were supposed to be drawing. So when the next frame down is an individual who has kind of mild Alzheimer's disease, mild to moderate. And he kind of gets the idea, he or she. Not perfect. And then, but you can see as the disease progresses, the ability to, that visual spatial ability to kind of translate what they're seeing and reproducing it just goes away. So this is just an example of how you can see this even on testing. And this is the right parietal region of the brain affected. Now, I think, again, and we started out with this whole concept that the disease doesn't just, you just don't go from being normal to having Alzheimer's disease. It's a long process starting with no symptoms, that as all these proteins accumulate in the brain, to when they start causing damage to different areas, and then eventually you end up with dementia. But that's, of course, at the end of the disease process. And the spread is like this. So this gives you a little better view. So this is a kind of early in the disease, and this is the tau. This is the tangles. So again, temporal lobe, kind of in the frontal lobe. This is very early. You see these type of changes. So you can get apathy, you can get memory, short-term memory loss, apathy, poor judgment or reasoning, things like that. Then, as the disease progresses, now it kind of just sweeps out into the parietal lobe, more into the frontal lobe, more behavioral problems, more difficulty with other tasks. And then eventually, as the disease gets into the moderate to severe stage, you can see that The pathology just is spread throughout the brain. And so you just get more and more deficits. Now, it turns out that there are variations on the theme. So some people have, and we don't understand why, perhaps it's related to genetic differences, very specific presentations. So instead of having that kind of sweeping pattern of going from the temporal lobe out, these individuals actually start with these proteins in specific areas. So one is called posterior cortical atrophy, or PCA. In here, the tangles and all the pathology seems to be in that parietal occipital region, so more in the back. And how it presents is with visual difficulty. So these people can see. There's nothing wrong with their vision, but they can't process the information. So in some sense, they are visually impaired. Memory may be a little affected, but really what's prominent is they can look at things, but they can't interpret what they mean. And then, of course, that eventually progresses as well. The logopenic dementia, that has to do with individuals where the pathology is primarily in the language area of the brain, on the left side. So again, their memory isn't quite as bad, but they just can't communicate. Can't get the word out. Don't understand, for example, what certain words mean. So it's mainly a language problem early on. And then again, eventually memory becomes more involved as well. But it starts out not so much memory. And frontal temporal dementia is a group of diseases which could be caused by Alzheimer's pathology. And that's where early on, it's just the frontal lobe. So you get behavioral problems, disinhibition, social inappropriateness, lack of empathy, and yeah, some memory changes, but that's not the prominent thing. So why these type of variants occur, we don't understand, but the pathology is still the same. It's still Alzheimer's disease, just kind of a different theme. Now, so understanding why the behaviors happen or why people do what they do is important, because then it may modify how you approach a person. If you can understand they're not just doing things on purpose, or they're not trying to get in your head. But then the question is, how do you treat them? And there's a couple of things I just want to highlight. And if you've come to these lunch and learns, you've probably heard these things many times in different ways, but it never hurts to kind of repeat them again. So first point is that if a new behavior starts, so somebody's kind of going along okay, and then they suddenly start to hallucinate, or they suddenly start to get agitated, or they suddenly start to get mean, the first thing we have to make sure is that they don't have something else going on. Now, it could be a urine infection that's common in women, or that it could be that they're dehydrated, or it could be that they have pain they can't explain, they're constipated, whatever. But usually behaviors don't just change. I mean, they're things that come on, but they come on gradually over a period of time. So that's the first thing. We always have to be alert to another problem that needs to be addressed. The second, I think, component is this idea of non-medical approaches to treating behavior. So there's many strategies, again, you can do. Alzheimer's Association provides a lot of information on this. I'm sure the classes here do too. But it's really, a number of things. These kind of make sense. One is to utilize your body language. Because sometimes, if you have Alzheimer's disease and the comprehension isn't that great, one thing, though, that often is retained is your ability to read body language. So if you're getting upset, that person reads off of that, and they'll get upset. So the whole idea of staying calm, and actually, it's interesting, and I was taught in medical school, the first thing you do if somebody has a cardiac arrest is you take your own pulse. Because the whole idea is that you have to kind of be centered if you're going to really care for somebody appropriately. So pleasant voice, good body language, which is comforting. Go slow. So again, if your comprehension isn't very good, and somebody's telling you to, go to the refrigerator, get the milk, then bring the bread over, and get some mayonnaise. I mean, that's too much. So breaking things down to very simple steps, so it's not as confusing, it can be helpful. Similarly, using very simple sentences and not trying to, go into a whole dissertation about something, a question. I think a big thing is this avoiding correction or confrontation. For whatever reason, and I don't understand it, some caregivers like to correct, or they like to remind people they can't remember. Like, don't you remember this? And of course it serves no purpose. I understand people get frustrated as a caregiver. That's natural, but for everybody's benefit, avoiding correction, avoiding confrontations, not arguing. I'm not saying if it's an important issue, if it's a safety issue or something like that, that's a different story. And you got to do what you got to do. But it's at a certain point, trying to correct somebody, argue, rationalize, is just not going to get you anywhere. You got to be flexible. So if somebody wants somebody to take a shower, they don't want to take a shower now. You don't spend a half hour trying to make them take a shower. Back off, do something else. And then kind of think about a different approach, or come back later. Distraction's always good. That is taking advantage of somebody's short-term memory problem. So getting off on a different subject. And then keeping somebody active, engaging in activities. The worst thing probably is just sitting around in front of a TV or sleeping. So having said all that, though, there are medications. So you can do all the right things, and it still doesn't work. So there are medications, and that often is needed. If we are going to use medications, the bottom part are the kind of recommendations. So one is you really you have to target the symptom that you think is important. And I will tell you, you really need to be an advocate when you talk to physicians or physician assistants or nurse practitioners. Now the hope is here, people will kind of ask you and really try to probe a bit. But if you just say, well, my spouse is agitated, that could lead to a lot of different medications. So you really want to narrow down what's the agitation. Are they just restless? Are they getting physically violent? Are they yelling a lot? Are they hallucinating? Because see, all those things may be treated differently. So, for example, for poor impulse control, that is flying off the handle, that's not a reason to use a heavy-duty antipsychotic drug. There are, antidepressant medications that will reduce that poor impulse control. There's mood stabilizers, and these drugs generally have less side effects. Now, if somebody's truly psychotic meaning they're having paranoia, delusions, hallucinations that are really bothersome to them, and all these things being bothersome, then there are drugs. These are antipsychotics, but keep in mind they all have a warning on them of an increased risk of stroke and death in older people with dementia. Now that doesn't mean that risk is very high. I don't actually believe it's very high at all. But these aren't like first-line drugs if somebody's just not sleeping. So you need to use them appropriately. And for sleep, again, there's a number of drugs that can help sleep. And there's a number of drugs that you shouldn't give for sleep. And again, that's, you just have to work with your physician on that. So medications are clearly sometimes useful, but it never hurts to do these other things as well. I put this in, problems with sleep medications. some of them, and these are things like Ambien or Restoril or Lunesta, they do, just in general, increase the risk of falls. They can increase confusion. And then the other big thing is then if you don't use them, so if you're used to using them and then you don't use them, you can get rebound insomnia. And by the way, this applies to everybody, not just people with Alzheimer's disease. So generally, sleep medications, sometimes they're necessary, but you don't want to, if you can help using them, that's better. So I'm going to give you a quiz to wrap this up. And then I'll leave this, we'll leave it open for questions. So I have on the left column certain functions, and on the right column, different areas of the brain. So I want you to match them up. So we'll start with memory. So what area of the brain is involved in memory?
Temporal.
Yeah, temporal. Temporal lobe, that's right. That's the hippocampus for the temporal lobe. How about calculations?
Left.
That's right, left parietal lobe. That's right. Okay, 2 for 2. Insight into illness. Right parietal lobe. Okay, we're right on there. Disinhibition. Frontal lobe, that's right. It's the frontal lobe that you get disinhibited, socially inappropriate, and so on. And rage reactions. Amygdala, that's right. All right, well, good. All right, good for you guys. Okay, so that's good. All right, so I'm going to stop here just with the formal presentation. And first, maybe I could ask if there's any questions in our other sites. So then we'll come back to Las Vegas. So either in Winnemucca or Hawthorne, do you all have any questions? Oh, nobody's here. Oh.
They've been talking to each other.
Oh, that's a drag. Okay, well, then we'll start with Las Vegas. Any questions about either what I talked about or other things related to kind of these different presentations? Or not? Yes?
Has there been any research or insight into why the progression goes from one area to another rather than affecting the whole brain more and more and more?
Yes, so the question is, why do we see this very specific distribution, why it spreads in a certain way? And despite all the great talent and knowledge in the world, no. I mean, the thought is, I'll tell you what some of the thought is. One is, which is really kind of interesting, is that this protein, this tau protein, can spread. So for some reason, the cells in that temporal lobe are very vulnerable after injury. And then you produce this tau protein. And then it actually can spread from cell to cell. And it just kind of spreads. And it just spreads into networks. Because there are networks in the brain, different areas that are kind of connected. So that's a very common theory. We don't know. But I guess the idea is that there's certain cells that are vulnerable. Once you produce these proteins, they can actually, on their own, spread from cell to cell. Now, if that's true, that gives us an opportunity, perhaps, in terms of treatment, because if you could stop that spread, you can halt the progression of the disease. Many of you know who have followed our research here, a lot of the drugs now are focused primarily on amyloid, because amyloid is actually more diffusely distributed throughout the brain, and that's very early. So the thought is, all right, let's get rid of the amyloid, and then you won't have the tau. But another approach, which some people are working on, is focusing on tau and how you actually stop that spread of tau. But we're not there yet. Yes.
The tau is the one that comes up.
Yes.
Around. Does that tend to be to one side of the brain, to the left side or the right side?
Yeah, so the question is, does this tau spread, is it more likely to be on one side than the other? And it turns out it can be on either side or both, and it's often asymmetric, meaning that, and again, we don't understand why. Some people can have more spread on one side, some can have more spread on another side. And there's no rhyme or reason, so we don't understand why that happens. But that's why some people have more language function, and their behavior may be fine, and they don't have any visual spatial problems. Or another person may have, totally no insight into their illness, but they can communicate, they can understand. And that's probably because of these asymmetries of how this stuff moves in the brain. But eventually, to be honest with you, eventually, it does encompass most of the brain, and both sides become affected.
I was reading in the Scientific American, they were talking about prions, and claiming that most of these degenerative diseases of the brain might deal with prions. Why is there a tendency not to mention prions, though? Why is there a tendency to keep shying away from that?
Yeah, the question is the concept of prions, and I didn't use the term, but that's what I was referring to in the previous question. Prions are proteins in the brain. They're normal proteins, but for some reason take an abnormal form and then can be actually transmitted. You can actually transmit prions from one cell to another. Maybe the reason people don't talk about it is that the hallmark prion disease is like mad cow disease. And there's actually a whole set of dementias. They're very rare, so maybe 1 out of 1 million people, that are due to a prion protein and that can spread very rapidly through the brain. I mean, within months, a person could go from being unaffected to being dead. It's a very rapidly progressive dementia. Mad cow. The other human form is called Creutzfeldt-Jakob disease. Yeah, Creutzfeldt-Jakob. So these aren't very common, but those are the classic prion diseases. But you're correct. The thought is that these other proteins can act like prions. That is, they may be able to spread. Now, their spread isn't over months; they'll spread over years. But that's absolutely correct. Is that the thought is that these diseases, once they get started, they can just kind of propagate on their own. And again, maybe a target for treatment at some point. That's correct. Yes?
Is there any data that shows how long people live with advanced Alzheimer's?
Yes. So the question is, the longevity of somebody with advanced Alzheimer's disease. Of course, it varies, and this is where the problem is, because we just have averages or statistics. We know from the time of diagnosis, so when somebody gets a diagnosis to death, is roughly 8 to 10 years, somewhere around there. Once somebody gets to an advanced state, then, of course, the time to death is relatively short. And that's because people then just become susceptible to other things, pneumonia, infection, trauma to the brain from falls. So again, just roughly, if you're at an advanced stage, the likelihood of going on 2 or 3 years is probably pretty low, because you just become susceptible to other things. Now again, those are just averages. So some people, will live with the disease even at an advanced stage for a long time, but that's not very common. Yes?
You define advanced stage. Is it an MMSE score?
Yeah. So so the question is, what do you call advanced? And maybe we should have clarified that. And in this case, I would refer more to function. So that is, if once an individual really has lost their functional abilities to toilet themselves, to walk, to feed themselves, to toilet themselves. So that's advanced. So once you reach that point, then you just become very susceptible to everything's happening. But again, there's a range even with that, depending on your general health. So, yes.
What about the athletes you hear all the time that have brain problems? Does that lead into Alzheimer's also?
Yeah. So the question is about the athletes that have repetitive head trauma. So we know that if you've had repetitive head trauma, whether it's playing football or boxing or even in the military, you're at increased risk of something called chronic traumatic encephalopathy, or CTE. That's different than Alzheimer's disease. So it's a different disease. It's thought to be kind of, in some sense, the same idea that you have this tau protein, specifically tau, and that it may, even though you're not exposed to head trauma anymore, it may spread on its own. But it just, what's different is it has a different distribution, there's no amyloid, it's just a different disease. We don't know how common it is, we don't know how much trauma you need, so there are a lot of questions to that, understanding that. Whether trauma can lead to Alzheimer's disease is not as clear. So there are some studies that suggest head trauma increases your risk of Alzheimer's disease, but there's others that don't show a very strong link. So I think the jury's out on that. But certainly you can get CT. Yes?
Can the tau and the amyloid be in any other body fluids besides the cerebrospinal fluid?
Yes. So the question is, can you find these proteins elsewhere in the body? And it turns out, no. They're not deposited in any organs. You can find it in the blood because stuff leaks out of the brain. So you can actually measure amyloid in the bloodstream. You can measure tau in the bloodstream. But as of now, they're not, their amounts are so small that we haven't been able to use them diagnostically or prognostically. So it seems like the amyloid that we find in Alzheimer's disease is specific for the brain. Just to make sure there's no confusion, there are diseases, amyloidoses, there's other diseases with amyloid, but it's a different amyloid. And that amyloid can be deposited in a lot of organs, but this is different, and you really see it unique to the brain. Yes?
When the patient shows a change in behavior, could it also be that they are coming into a moment of complete clarity and they're angry, they know what's going on, they know where they are? And
yeah, so yeah, the issue of when you see an abrupt behavioral change, could it be just more insight into their illness? Certainly, I think there are people that recognize and are frustrated with the issues, with the problems, or they have partial insight, and that frustration can come out. But I guess I was referring more to individuals who are pretty much have been on an even keel, and then suddenly more than a day, really kind of tank, and just totally change personality. And I think that that should just be a signal to look for other things. But I'm sure, if you're frustrated and so on, that can lead to.
How often is Alzheimer's coupled with Parkinson's then?
Yeah, the question is, how often is Alzheimer's disease coupled with Parkinson's disease? And that's also a bit of a difficult subject because we know pathologically, and again, these are things that we really have been learned over the last maybe 10 years, but just looking at brains and being able to examine more with our new techniques, that actually in older individuals, I'm talking about 80 and above, it's actually more common to find several pathologies than just one. Instead of just seeing plaques and tangles, often you will see Lewy bodies. Lewy bodies are what you see in Parkinson's disease. So we know that there can be, again, the older you get, the more likely you might have a mixture of things. So yeah, having Alzheimer's pathology and Parkinson's pathology as you get older are not that uncommon. I can't give you an exact number. But keep in mind, again, there is a disease, Lewy body disease, which is just Parkinson, the features of Parkinson's disease, but those people also have memory problems and hallucinations and sleep problems and such. So Lewy body disease is a disease. You can have Lewy body disease and Alzheimer's disease, and then you can have Alzheimer's disease with Lewy body. So I think what we're just understanding is that it's not tremendously unusual to have some combination.
Then is this Lewy body's disease, isn't that part of Parkinson's, or is it?
Yes, so Lewy body disease, what we think is Lewy body disease, well, Lewy bodies are the hallmark of Parkinson's, so just like amyloid is the hallmark of Alzheimer's. And there's a spectrum. So on one end of the spectrum are people that have garden variety Parkinson's disease. So these are folks that start out with the tremor and they're shuffling and they're kind of stooped over. And then later in their disease, 10 years later, whatever, they start having memory problems and such. On the other end of the spectrum are people that have what we call dementia with Lewy bodies. And they start out more with the memory part. So the memory, and the Parkinson features are very minimal. But then over time, they get more of the Parkinson features. So we think it's kind of a spectrum of conditions, and it, again, probably just depends what area of the brains are involved. You know, are the Lewy bodies throughout the brain? Are they just in the movement area of the brain? And there may be, again, other factors, genetic and such, that determine that. But it is, you bring up the point that as we get older, as we all age, you just become much more susceptible for these proteins to be deposited in the brain, and your ability to handle them, to get rid of them, probably declines.
Thank you.
Yeah. Yes?
I heard as you age, the brain or within the skull, that water accumulates. Can you explain that? And is it also like a head injury where water fills the
Yeah.
skull and needs to be drained?
Yeah.
If they're elderly? Can you explain that?
Well, yeah, so the question has to do with the kind of accumulation of water or fluid in the brain.
Yeah.
And there's two circumstances that occur, really. One is a disease. We call it normal pressure hydrocephalus. And in this disease, what happens is that there's a blockage in the flow of the fluid, and it just builds up. So it's like an old sink, and it gets plugged, and then the fluid just kind of backs up. And that causes memory problems. It causes difficulty with balance. It causes incontinence. So, and if you drain it, the person gets better. The other situation, which probably is more common, is that as you lose brain tissue, whether it's from Alzheimer's disease or Parkinson's or whatever, something has to take up the space, and it's the fluid. It's the spinal fluid. So
the death of the tissue will make the brain shrink a little, or?
well, if the diseases progress and you're losing brain cells, then the brain will shrink and the fluid takes up the space. And in that situation, draining the fluid doesn't do anything. So there's two different diseases. One, which is normal pressure hydrocephalus, which is a disease, and the other is just the buildup of fluid because the brain is shrinking. So, and that has to be, you just have to sort that out diagnostically. Yeah. Have a couple more minutes. Any other questions? Yeah.
Yeah, do we know now how much of Alzheimer's is genetically based?
Yes. So the question is about the genetics of Alzheimer's disease. And we know a fair amount of that. So we know that there are certain families where the disease runs, and it really is strictly a genetic problem. It's due to a mutation in the gene, meaning that there's an error in the gene, and that error gets passed on from generation to generation. And if you have that error, if you inherit it, you're going to get the disease 100%, or almost that. But what's probably more common is what we call susceptibility genes. And in this case, there's a gene, which is a gene, just directs the production of certain chemicals in the brain. So you could have a gene that just normally has several different forms. So it's not really an error, it's just kind of a different form of it, or a variation of it. And one of those variations puts you at a higher risk of getting a disease. So in other words, you can inherit that, but never get the disease, because you may have other things that protect you. So we know we can actually measure that. That's ApoE. ApoE4 is the one that's associated with Alzheimer's disease, yeah. And there probably are other ones that are not quite as potent. So, I think the feeling is that, yeah, genetics play a big role or an important role in determining if you're going to get the disease. The problem is, you have probably other factors, other genes, other things, lifestyle changes that may help protect you in some sense, or may cause the onset to be much later. So, the genes you're stuck with, but there may be, aside from mutations, there may be things you can do to modify your risk, is what the thought is. Yeah. Well, Jasmine, I thank you for hosting us.